Okay, good afternoon, good evening, and good morning, everybody, whichever you are. So this is our weekly webinar presentation from TORG Sierra Leone chapter. So we really appreciate all of you guys to give us your precious time to step in and to attend this webinar. So today we will have Foday Daddy Mansaray, who is going to present the Perimortem Cesarean section. It's a life-saving procedure in maternal cardiac arrest. So before I give a chance for Mr. Kalo as our secretary to read the guest introduction of the guest, I will make you sure that the presentation going to be very interactive, and he will have 40 minutes to present. And if you have any question, ambiguities, any additional point, please, you are kindly requested to write it down on the message box. And lately, we will have 10 minutes for discussion, the question and answer session. So you can still entertain your questions and additional contribution point after Foday present his presentation. Having said this, due to the time interest, please, if Emmanuel Kaloko, if you are around, please confirm for us.
Yes, I'm around.
Okay, Emmanuel, over to you, please. You have 5 minutes to introduce our guest speaker on behalf of TORG Sierra Leone. Thank you very much. Nice to have you around.
Okay, thank you very much. My name is Emmanuel J. Kaloko, the PRO Sierra Leone chapter. It is a pleasure being introducing the speaker of today's webinar, Mr. Foday Mansaray. Ladies and gentlemen, Mr. Foday Daddy Mansaray is a dedicated healthcare professional from Sierra Leone, currently residing in Kono City. He holds a diploma and a Bachelor of Science with honors in community health and clinical sciences from Jala University, Sierra Leone. A Bachelor of Advanced Clinical Skills, he completed a postgraduate diploma in general surgery with a specialization in obstetric and gynecological through the Kappa Surgery Training Program. He also based in Sierra Leone. With over 7 years of experience in clinical and surgical practice, Foday currently serves as an emergency surgical officer with Partners in Health in Sierra Leone. In this role, he provides essential surgical service in resource-limited setting and is actively involved in improving health outcomes for undeserved populations. His professional passion lives in a maternal and clinical health with a strong focus on reducing preventable complications and mortality. He is deeply committed to deliver timely, evidence-based care to vulnerable groups, particularly women and children. Looking ahead, he aspires to further specialize in obstetric and gynecological to explain its impact on maternal and reproductive health in Sierra Leone and beyond. At this webinar, Mr. Foday will present on post-perimortem cesarean section, a life-saving procedure in maternal cardiac arrest. His talk will explore the critical timing, indications, and procedure steps on this high-stake intervention, drawing on real-world experience and evidence-based practice to highlight its life-saving potentials in maternal emergency. Mr. Foday Daddy Mansaray, you are welcome, sir.
Thank you very much to the PRO. Thank you very much to the president, the operating room global Sierra Leone chapter for this invitation to speak here on my Perimortem Cesarean session. I appreciate you all. Hello, everyone. Are you getting me?
Yes, sir. You are right on point.
Okay,
Yes,
so are you seeing also my slides?
We can see, please proceed. And if you can expand it, but we can clearly see that.
Okay. Show full meeting. Okay. Is that clear?
we can see your screen. We can see your slides.
All right.
And we
Thank
can
you
hear
very
Clear
you
much.
now.
clearly.
It's clear now. Please proceed.
Yes. Okay. So we move on. Thank you very much, everybody. I want to appreciate the TORG Global Sierra Leone chapter for inviting me to speak into this forum today. And I want to thank the president especially and all the executive members for inviting me. So our topic of discussion is going to be based on perimortem cesarean section, which is a life-saving procedure in maternal cardiac arrest. So good. The introduction has been made by the PRO. Like he said, I am Foday Mansaray, currently serving as emergency surgical officer, working for Partners in Health, Koidu City, in Kono, Sierra Leone. So if you can see my slides, we are going to go through these outlines. We will talk about the introduction. We want to know about the etiology of cardiac arrest in pregnancy and how do you define it? How do you go about the cardiac? How do you go about the procedure of perimortem cesarean sections for a woman in a cardiac arrest, especially for a pregnant woman, and the approach we take, and then we summarize everything. So as we move on, the importance of this particular topic today we are talking about is for global burden. Maternal cardiac arrest is a global burden, though it is rare and occur in every 12,500 pregnancies, one in every 12,000 pregnancies. So which is the fact it can be life-threatening and very fatal sometimes based on the setting you find yourself. And so that is the reason why I want to discuss this particular topic tonight, so that we can all be on the same footing, and then we can share our experience, and we'll share the experience we have here in our setting. As we speak, the most common causes of the cardiac arrest in pregnancies that we actually leads to cardiac arrest in pregnancy. The most common causes are based on percentages, which are highlighted here, which it says that hemorrhage, which we serve as 45%, that will lead to cardiac arrest in pregnancy. Amniotic fluid embolism is also another important contributing factors. We serve as 13% globally. This is global burden. Heart failure is also another cause of cardiac arrest in pregnancy. Also is 30% globally. Anesthetic complications is 8%, and trauma, which is 3%, that will affect pregnant women globally. So how does this one occur? The etiology of maternal cardiac arrest, we categorize them in alphabetical order. We say anesthetic complications we serve as one of the causes of cardiac arrest in pregnancy. Bleeding, and we know bleeding will come from, let's say, obstetric hemorrhages, maybe ruptured uterus, or maybe postpartum hemorrhages. So it's also the cause of cardiac arrest in pregnancy. Cardiovascular diseases, as they see, factor that will lead to cardiac arrest in pregnancy. Cardiovascular disorders like myocardial infections or peripartum cardiomyopathy. So these are all contributing factors that will lead to maternal cardiac arrest in pregnancy. Drugs-related factors, especially for, like, let's say, with hypertensive disorders and a woman is on magnesium sulfate, and then there may be, let's say, magnesium toxicity. So these are one of the drugs that will lead to cardiac arrest in pregnancy. Embolism is also another contributing factor. Where sepsis is also another contributing factor that will lead to maternal cardiac arrest. And for general non-obstetric causes, especially like trauma, will also be a contributing factor that will lead to cardiac arrest in pregnancy. And the H and the T's, which we all know, and then there will be a slide that we will see and which we will talk about, which are all contributing factors that will lead to cardiac arrest in pregnancy. And then hypertension, especially obstetrics, hypertensive disorders in pregnancies. These are contributing factors that will lead to cardiac arrest in pregnancy. So, so it is a global body, just like I said before. But though it is a rare event that we occur, but most of the time it is fatal, and most of the times patients will revive or will recover from it. So as a global body, it says that we occur in 12,500 pregnancies, 1 in every 12,500 pregnancies globally. And the most common causes of cardiac arrest in pregnancies, hemorrhage, contributing to about 45%, amniotic fluid embolism, 13%, heart failure, 13%, equal level, anesthetic complications, 8%, and trauma. And trauma will fall under non-obstetrics causes of cardiac arrest in pregnancies. So these etiologies, we want to discuss them based on alphabetical orders. Like we say, anesthetic complications, bleeding, cardiovascular system, drugs complications, embolisms, fever, which signifies sepsis or infections that will lead to cardiac arrests in pregnancy, the H and the T's, and hypertensive disorders. Now you can look at what the H and the T's are talking about, which are the reversible causes of cardiac arrest in pregnancy: hypoxia, hypovolemia, hypokalemia or hyperkalemia, hypothermia. These are the H that are reversible causes of cardiac arrest in pregnancies. And the T's, we say tension in pneumothorax, thrombosis, tamponade, and toxins, drug toxicity. These are all reversible causes of cardiac arrest in pregnancy. So if you actually want to be very much prompt in your actions, you need to know the signs and symptoms of cardiac arrest in pregnancies. So some of these signs and symptoms of cardiac arrest in pregnancies is a feeling of extreme dizziness. The patient will tell you that I am feeling dizzy, or we have shortness of breath, or feeling pain in my chest. These are some of the complaints that our patient will say. Or I am feeling my heart is beating faster, palpitation. These are some of the signs the patient will tell you, or the symptoms patient will complain about. And then you will feel that the patient has no pulse, and or maybe you find the patient collapse, or maybe feeling weak or fatigue, or will fall over, Maybe you will see the patient we having nausea or urge to vomit, or maybe you find a patient that is having difficulty in breathing, or maybe you see patients having loss of consciousness. So these are all the signs and symptoms of cardiac arrest in pregnancy. So how do we define perimortem cesarean sections? This is our main topic, main focus for today. We say perimortem cesarean section. It's also known as the resuscitative hysterectomy, which is an emergency procedure, surgical procedure, which can be performed when a pregnant woman experiences cardiac arrest. You understand? And the primary goal of this particular procedure is to improve on the chances of maternal resuscitation. How? By relieving the pressure on the heart and major blood vessels. And at the same time, you are attempting to save the baby. So this is how we say perimortem cesarean section is defined. And the benefit, the why and the when, what is the benefits of these perimortem cesarean sections? Of course, when you deliver the baby, fetal oxygenation is very adequate. You deliver the baby and then the baby is out and you hand it over to the resuscitation team for the neonatology team to take over. And at the same time, the maternal oxygenation is also met because you have improved on the circulation. And then the oxygen demand have been taken care of, the perfusion, the aorta cover, because by delivering the fetus, you've reduced aorta cover compressions on the uterus. And why is it so specific or that pregnant women are so special to take care of when they have cardiac arrest than any other population? Because of the physiological change. You know, they are very quick to experience rapid desaturation when they are pregnant. And then that also will lead to also poor cardiac responses because of the uterus itself with all what it contains will be pressing on the abdominal aorta that will compromise blood supply. And you know, and the well-being of the patient wholly and solely depends on the mother. So as long as you save the mother, you relieve and you create a very good circulation for that mother, the fetal well-being is adequate. And you know, the airway for pregnant women, particularly, is very difficult to handle as long as they are pregnant. So it is very good. It is an advantage if you take care of them when they are in cardiac arrest, so that you can create an adequate ventilation for them. And you also can create an adequate circulation. The cardiac output can be very much improved on, and the saturation can be improved on. So these are the differences and the key advantages that they have that makes us to take care of them more than the general population or somebody who is not pregnant. Yeah, because they are carrying baby, and then we want to save them. I want to protect the baby as well. I want to save the baby. So according to the Royal College of Obstetricians and Gynecology, perimortem cesarean section should be performed if there is no response after 4 minutes of correctly, or maybe we say highly performed CPR in a woman who is greater than 20 weeks of gestation. This is global standard. For a setting that is well equipped, we think about expertise, think about equipment availability, and they are recognizing 20 weeks of gestation. For Sub-Saharan Africa, especially Sierra Leone, where we are resource limited, we lack the expertise, we don't have the equipment. our age of viability for every pregnant woman, we consider it to be at 28 weeks of gestation. But for global standard, they are saying 20 weeks of gestation. So at 20 weeks of gestation, a woman with a cardiac arrest, that you have to consider to do perimortem cesarean section within 4 minutes. And now within 4 minutes, you start your perimortem cesarean section. By the time you arrive at 5 minutes or in 1 minute's time, you deliver the baby in 1 minute's time. So according to studies, they have seen if you wait more than 5 minutes, maybe you go to 6 minutes or more, which can be possible in some areas. They are saying the maternal hypoxia brain injury will have occurred, and the baby depends wholly and solely on the mother. So you cannot save the baby. You can only save the mother. So you do your perimortem cesarean section at 4 minutes. By 5 minutes, you deliver the baby, and then you will achieve what you are looking for. If you wait more than that, and then your maternal hypoxia, the brain injury will have occurred, and then that baby will not survive. And the indication, like we said before, is 20 weeks, which is global standard. Some we say 24 weeks of gestation with a woman who is pregnant and with cardiac arrest. You can perform perimortem cesarean section. And some we say for our setting, we say 28 weeks of gestation, which is our own age of viability here. We consider to do perimortem cesarean section to save both the mother and the baby. And the goal for us to save both mother and the baby. That is the actual goal we want to achieve. And so this one is a global standard. 4 minutes, and then by 5 minutes, you deliver the baby. And then because of time, here we want to consider time. It is time bound. You don't have to wait until a woman, you don't have to wait. You want to carry the woman to the theater and you waste a lot of time. So the moment a pregnant woman goes into cardiac arrest, at that site, you have to do a perimortem cesarean. So within 4 minutes, you deliver the baby to save that woman and also the baby. Do not wait. Say you want to carry the woman to the OT or to the operating room. You will waste a lot of time. That will create a lot of interruptions to the resuscitation, and that will hinder the process or the procedure that you are carrying about. So the procedure is actually like as long as you are carrying the resuscitation, and then you have team members, at least three team members, which are available. You can call for help for more, but at least three teams. Maybe you have the surgeon and you have the assistants, and then we have who will resuscitate the baby. Then you can carry on your procedure at bedside. As long as you have your scalpel, you have your scissors, you have the suture materials, you are good to go. Yeah, the incision for some settings, but for very good room space for you to get an adequate access to the abdominal cavity, recommended is lower midline. Though they are saying you can do midline from the xiphoid process to the symphysis pubis, which we have not done in our own setting, but it depends based on the size of the uterus. But what is recommended for good adequate space, you do your midline. For us here, we have been doing our Frankenstein incision. You go in, you get your baby out as fast as possible. So delivering of the baby, you have to be very fast at it. You get the hair out of the uterus, you clamp. At the same time, you have a support supportive assistance to assist in the fundal support. You scope the placenta. Sometimes you can do it by control cord traction, or you can also just scope the placenta out as fast as possible. So here, speed is our main key. You know, we consider speed here. Yes, IPC can be maintained, but yeah, we cannot focus on IPC at this moment, as long as we want to save the mother, particularly we want to deliver the baby. So the reason why we do this, especially, is to create a redirect blood flow for placenta. You know, when the woman is pregnant and all the blood flow between the placenta and the mother is very huge. So the moment you deliver the placenta, baby is out, all the blood flow will be redirected to the mother alone. And then you have relieved the pressure on the IVC. And then you make sure you control or you improve on ventilations. Of course, delivering of the baby has to be as soon as possible. And then you want to deliver the baby, you want to undertake this procedure, they say it's in 2 ways. You have to consider the mother and the fetus. So make sure you gather all the expertise that are needed, people who can take care of the mother and the resuscitation team for the baby. So you remove the baby and you hand over to the resuscitation team for neonatal resuscitation. Provided if you have a single baby or multiple, if you have multiple babies, it all depends. But you have to do it as fast as possible in order to save. Our main goal is to save the mother. And then there should be a call to action. You recognize cardiac arrest in pregnancy. Maybe you are a nurse and you are attending to a patient who's critically ill. You have seen signs of danger signs, and then you recognize that this woman is not responsive, and which is cardiac arrest. Make sure you call for help as soon as possible, because this is what makes it key, what makes it time bound for you to save this mother. So you call everybody on board that are really needed to save both the mother and the baby, which we include emergency physicians or nurses, or midwives, obstetricians and scrub nurses, anesthetists and the assistant, neonatologist, and the team leader. The team leader need to be in place, because he or she has to oversee and make sure the procedure or the event are in correct order. And also, you do not have to forget somebody who will take note of the time and all activities that are being rendered for this patient during this procedure. So how do you go about this, the approach of pregnant women during cardiac arrest? We say the early recognitions, of course, we say you recognize the signs and symptoms of cardiac arrest, and then you call for help. And then once you call for help, immediately you have to start your CPR. And then if possible or indicated, you do your early defibrillation, if it's shockable or not shockable. And then at the end of the day, if the patient returns to spontaneous circulations, and then you maintain the post-resuscitation care. And you make sure you take care of what are the responsible factors that has contributed to the cardiac arrest in pregnancy. And the approach has to be very safe. You check for signs of life, just like we have spoken before, as whoever is taking care of this critically ill patient, maybe in the hospital or maybe just arriving or maybe around, you have to take note of the signs and the symptoms. This woman is responsive or not responsive, or maybe you see that the woman is gasping occasionally, and then you recognize that this woman is in a critical condition. So you have to shout for help, and you call the team members that will render the resuscitation. And the resuscitation, according to the standard, it has to be, the ratio has to be 30:2. And if there is possibility for defibrillation, so you attach the monitor. And that is why the anesthetist, as you have called, should be on board, because the anesthetic assistant will be available to provide the monitor and to check whether this particular arrest is shockable or not shockable. And the skill for those who are going to carry out the resuscitation should be very much based on competence. The skill for chest compression, and the airway management for the anesthetist, and the cardiac monitoring should be very much adequate. How do you carry out this particular procedure? You make sure a woman who is pregnant and in cardiac arrest, you place her in a full left lateral position, and you make sure an adequate 100% oxygenation is provided for this woman. And then you make sure you establish an intravenous IV line. They are say recommending that you pass an IV line that is above the diaphragm, which is most of the time maybe jugular or central, because you don't want an obstruction from the gravid uterus to interrupt whatever administration, drug or administration you will administer to this particular patient. And then at the end of the day, you have to take care of all the contributing factors or the precipitating factors that has contributed to this cardiac arrest to this pregnant woman, according to the American Heart Association. And then here you can see that they are trying to displace the gravid uterus in order to prevent to cover compressions, which is very key because you want adequate perfusion to go back to the mother. So this is how you carry out about this particular manual left uterine displacement. So you move the gravid uterus away from the aorta so that there should be an adequate supply of blood back to their heart. And then for obese woman, you can see the demonstration. Maybe you will scope the uterus and you move it to the left lateral. Why is the woman in a very tilt position? And then you scope the uterus away, and so that you will have an adequate perfusion to the uterus. Then in the process of this event, they are recommending to administer an adrenaline, 1 gram of adrenaline, either by IV or intraosseous, for every 30 to 15 minutes during adult cardiac arrest. And then every drug should be of standard. You cannot just administer any drug that you want to give. It should be on the adequate or recommended doses, because you are saving the life of the woman. And for the fetus, they are saying you do not have to waste much time to monitor the fetus. This will waste a lot of time because our focus is on the mother. You want to save the mother, particularly, though we want to save the baby, but you should not waste time to resuscitate the fetus. So for every device that is attached to the mother, for you to monitor the fetus to be detached as soon as possible, because this will create delays or we create hindrance in resuscitation. A resuscitation should not be delayed for more than 10 seconds according to standard. And when you are carrying out this particular procedure, you also remember you have to call the other team members, the neonatal team. You have to inform them that this is what we have, and this is the mother that we have who is pregnant. She has a gestational age of 20 weeks or more, as the case may be, or 24 weeks or more, according to the setting you find yourself. And then you tell the neonatal team that the number of fetuses that is found, so that they can prepare themselves and they can carry out their resuscitation, neonatal resuscitation separately, so that there will be no interruption to carry out your resuscitation for the mother. How do we carry out this resuscitation? They say it has to be a qualified CPR. CPR, you push hard to the depth of 5 centimeters, and you push faster, which can be more than 100 beats per minute, or so that it can allow full chest recall. So full chest recall, so that the heart itself can accumulate more blood, so that by the time you compress or you push another time, there will be an adequate blood to push into the entire circulation. You should minimize interruptions, and there should not be an excessive ventilation. Do not establish any excessive ventilation for this particular patient. And for avoidance of interruptions, maybe those who are carrying out the compressions, we interchange in every 2 minutes. That is what the standard is saying. And the standard says that 30 compressions to 2 rescue breaths should be established to carry out high quality cardiopulmonary resuscitation. And then for effectiveness, you have to place the patient on a very firm surface in a supine position. Maybe you tilt a bit the hip to allow the relief of intercover compression. And you have to be on the side of the patient. You kneel down, you hands straight. Maybe you calculate the sternum, the length of the sternum. Maybe at the half of the sternum, you press your first heel of the hand, and then you overlap with the other hand, and then you go deep up to 5 centimeter depth for you to be able to get an adequate chest recall. So that is what the standard is saying. So this one you are seeing is all talking about the correct way of carrying out cardiopulmonary resuscitations, which we have already spoken about. And then this one also we have also spoken about. We are saying 30 chest compressions at a rate of 2 compressions per second, which we allow 100 to 100 times per minute for effective or for quality chest compression. And you want to maintain the airway, just like in a normal adult. You have to tilt the head, patient in a supine position, to tilt the head. You lift the chin to establish a very clear airway, so that you can be able to ventilate very well. Of course, you do not have to give an excessive ventilation into this particular woman. And then you are for an experienced anesthetist, should carry out its responsibility during this process to apply an intubation with a size of 6 to 7 diameter, which is recommended. And then there should not be an optimally more than 2 times for you to apply your intubation. If you have attempted 2 times and you have failed, you should not prolong, or you should not continue, because you don't want to interrupt the oxygenation, or you don't want to interrupt airway, or you don't want to create more trauma to the airway or bleeding to the airway. Where it is applicable, because you have your assistant, you can fix your defibrillation for shockable causes. If you think that you need to shock this patient according to your settings, because we in our setting here, we are resource limited. We have not used shockable defibrillation. But where it is applicable, and then it is indicated that you should use your shockable defibrillation, you shock the patient once, and then you carry out your resuscitation. You have to still carry on your resuscitation first, and then when the monitor is applied to the patient, and then you see the reading that this one needs or requires shockable defibrillation, and then you can apply the shockable defibrillation, and then you carry on, continue your resuscitation, cardiopulmonary resuscitation. So when do we stop? When do we stop? When do we say we want to stop this particular procedure? If your woman has returned to a spontaneous circulation, you do have to stop. You do not have to continue. Or you have continued within 20 minutes or more, and with all efforts, and the woman has not returned to spontaneous circulation, and then you have to stop. And then maybe you have your leader, you have your team lead who is leading this particular event. We tell you that there is no signs of spontaneous circulation there. We have to stop. We have to stop. It is more than 20 minutes. We do not have to continue. And you have seen obvious signs of irreversible death, then you have to stop. You do not have to continue according to standard. So, but in an area wherein you have achieved return of spontaneous circulations, and then you will carry on your management. You manage the airway and the respiratory. You make sure oxygen is adequate. You give your oxygen O2 support as adequate, and then you maintain your saturation more than 94%. And then, of course, you have to think in mind that you do not have to give an excessive ventilation. And then, so hyperventilation should be avoided. So in an area wherein a patient has a hypotension, then you manage accordingly. You manage accordingly, and you give your IV or IV fluid or by bolus wherever necessary. And then you identify the treatable causes. We have spoken about the treatable causes of cardiac arrest in pregnancies. Those causes that can lead to cardiac arrest in pregnancy, and then you treat accordingly. So in summary, you want to put everything together. In summary, we say we start with high quality cardiopulmonary resuscitation. You go on with your defibrillation when it is indicated, and you do every interventions, administration of therapies where it's necessary, 3 to 5 minutes of 1 milligram of adrenaline. It should be established, should be administered. And then secondly, you make sure you have assembled all your maternal cardiac arrest team. Your team should be alert, and they should be called upon so that they can come and carry out the resuscitation. So you do not have to forget. So that is why those who are actually taking care of this particular patient in inpatient or in a critical ICU, or where they are, and then they have seen that there are deteriorating signs or danger signs or an obvious signs of maternal cardiac arrest, they should be able to carry out basic life support whilst they are calling for help. And then you consider what has contributed to the particular cardiac arrest in a pregnancy. You perform your maternal interventions. You carry out your maternal intervention. Make sure you manage the airway. Consider to give O2 support make sure you avoid excess ventilations. You establish your IV line. The recommending that should be above the diaphragm. For it to maybe not to obstruct any drug administration because of the gravid uterus. And then if that particular patient is on magnesium sulfate, you have to stop it, and then you consider to give calcium gluconate. And you continue your basic life support, high quality cardiopulmonary. You have to continue doing that. And then you defibrillate where it is indicated, and do any interventions, drugs that are necessary for this particular life-saving, so that this patient can revive. So that is very key. You have to administer drugs. And then you go ahead and you perform your obstetrics, you perform obstetrics interventions like providing continuous lateral uterine displacement to prevent atrial compressions. You have to detach the monitors. If you want to consider monitoring the fetus while you are resuscitating the baby, it cannot work. The key here is to monitor the take care of the mother and to save the mother, and then remove the baby as soon as possible. And then you hand it over to the resuscitation, to the neonatal resuscitation team, which comprises of so many team members that have the expertise to carry out neonatal resuscitation. And then you perform the perimortem cesarean section within 5 minutes. Within 4 minutes of your cardiopulmonary resuscitation, you carry out your perimortem cesarean section, and then you continue with your procedure. Sorry, this slide is, I have lost this slide. Hello, everybody. Are you getting me?
Loud and clear.
Yes, we are.
Lost
Yes,
my slides. Sorry, wait a minute. All right. Are you there?
Yes, please.
So in summary, we are here. So when you remove the baby and you hand it over to the neonatal resuscitation team, whether it's a single baby or multiple babies, you have to inform them earlier in time. And then you also tell them about the gestational age, which is very key. So you inform them about, so that they can split or they can carry out their resuscitation effectively. So here, what will be our take-home message for resuscitation in pregnancy? We say it requires a specialized approach. We focus on the mother, actually. Although we are focusing on the mother, but at the same time, we want to save the baby as well. But you do not have to waste time monitoring the baby while you waste a lot of time or delay in carrying out your resuscitation of the mother. And then for any drug administration that is not recommended should be avoided. And every procedure should be carried out within 5 minutes. And you should not go beyond 5 minutes, because if you go beyond 5 minutes, by the time you arrive at 6 minutes, there should be a maternal hypoxic brain injury, of course, which will not be favorable for the baby to survive. The baby will not survive because the baby wholly and solely depends on the mother. So also, in summary, like we have said, you make sure this perimortem cesarean delivery is performed within 4 minutes. And then recommended gestational age should be 20 weeks for global standard. And then for settings where you find yourself and where the expertise, equipment, and everything is available. For us here in Sierra Leone, we consider age of viability at 28 weeks of gestation. And that is where we consider our fetus to be viable. So we most likely consider perimortem cesarean section when a pregnant woman goes into cardiac arrest and the gestational age 28 weeks, and then we try to deliver the baby as soon as possible. And then here the time is what is so much important. It's so much important, and then we do not have to waste time on of maintaining IPC. Yes, and IPC can be maintained if you have the time, but we should not waste time on IPC. That is why we consider doing it at the site where the mother has got the arrest, and then we carry on our perimortem cesarean section as fast as possible, and you inform the team members for neonatal resuscitation. You inform them about the gestational age and then number of babies that are available. Thank you very much for giving me your audience.
Thank you, sir.
Thank you very much for the for this detailed presentation. Thank you very much. We now open up to question and answers. So questions from the general members, some general public, sorry. So we entertain questions. Yes, Stephen, you can ask your question.
Yes, thank you very much to the presenter. You did very well. I just have some few questions to ask. So I just want to know, like, what are the ethical considerations you need to consider, one, and some of the aims and objectives of performing the perimortem CS. And lastly, in your own locality, like the site you are working, what are how many of those cases you have come across, and what are some of the success and the one that you guys are successful to do and the one that are not success?
All right.
Okay.
Thank you very much, Mr. Simi, for that wonderful questions. So you are talking about the ethical considerations, right? So ethically, you consider of informing the mother, the relatives, and if there is time for you to agree or to sign a consent form for this particular event to be carried out, maybe pre-event planning, you have to consider that before ever you carry out this particular procedure on a mother, a pregnant woman who has had cardiac arrest. The aim is to save the mother. That is the first key. But also, in the event of saving the mother, you have to also save the baby. So you try as much as possible to save the mother and do not waste time in doing that, and then you do not delay because you want to save the baby as well, and then you delay or you discontinue your resuscitation of the mother. So that is very key. But for our setting here, we encounter maybe a few number of cases which we have done perimortem cesarean section. Sometimes we at the end of the day we have not gotten a successful return of spontaneous circulation of a mother, which we have tried to actually save or revive from a cardiac arrest based on our setting. But we have gotten a few number of those cases. We have attempted to save the baby. One of those cases, I think we have achieved of saving the baby, because although the aim is actually not saving the baby as the mother, but in the event, we want to save the baby as well. You
So,
understand?
like in addition, yes, in addition to that, okay,
yeah.
In addition to that, looking at the question Timmy tried to ask, what are these what are the cases we already done in looking to our setting and the success rate? And actually, in our own setting, I think we have done up to 3 cases. I think the success rate here is 90%. Of course, there is a case of Perimortem CS done in a pregnant woman, a multigravida actually. So Perimortem CS was performed and the mother is saved and together with the twins. So that's a great success. And also a month ago, there is also a Perimortem Cesarean actually we did not succeed in saving the mother. And also there is the first Perimortem CS which was done wherein the mother and the baby, both of them, we are in our own setting here is we have performed this CS, this Perimortem CS. Thank you.
Thank you very much, the president, Operator Room Global Sierra Leone chapter. To you, Mr. Temi, I don't know whether your question was answered very well, but I think you've heard what we have said so far. Do you have more questions to ask? Or maybe other listeners, we have questions to ask. Hello, everybody.
Okay, Mr. Foday, there is a question from the chat box.
Yes, Mr.
There are questions from chat box, please.
Yeah, let me come, Mr. Foday.
Okay.
There is questions, Mr. Foday. Of course, this is trying to ask. My question is, are there any ethical consideration or issues associated with this performing this Perimortem CS? If yes, how can they be addressed?
Oh, okay.
So this is one question from one of the from Danjuma. Yes, Mr. Foday, you have your consideration. Yes. Once more, he's asking for issue associated with performing this Perimortem CS. If yes, how can this be addressed? So this is a question from Danjuma, Mr. Danjuma. Thank you.
All right, thank you very much. So, ethical consideration should be met. Yes, I want to say yes, because ethically you cannot carry on any procedure on a patient without obtaining an informed consent or consent from the patient or relatives. So you have to consider that as well. You have to inform the relatives. Maybe the patient will be unconscious and will not be in place to give a consent or accept whatever procedure you want to carry out. So relatives around will be involved into this. And you tell them what is going to be done for this patient, and then they will accept. And then you move on. So I think that is one considerations that you have to make.
Okay.
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 So
Yeah.
on top of that, more contribution on Foday. Thank you very much. Yeah, all our audiences, the legal framework is challenging. Yeah, we understand. It even influence our decision making. Yes, the international standard is that the hospital must have ethical protocols when it comes to emergency care. As you know, this perimortem cesarean section might be done in emergency department, even in the ambulance, even wherever it is, as Foday clearly mentioned. So the international protocol is that the hospital must have ethical protocols for specific cases like this. Yeah, when it comes to the how we are going to obtain that consent, the best thing is that the team lead, probably emergency physician or obstetrician, while he is assembling his team, he must communicate to one of the family member, considering that the patient is not competent to give consent, she's unconscious already or have signs of cardiac arrest. So the first thing is to obtain consent from family member, the best one from her husband, if not from whosoever around, quickly. But what if we don't have anyone to give consent? Right? I think that is a question from Jujuma and Doctor from Ethiopia. The consensus is that we have to also involve the hospital management, or we have to abide by the hospital protocols when it comes to emergency response. So the international recommendation is either you obtain consent from family member, or you have to follow the hospital protocol, and also you have to engage the hospital management for quick response. But in the meantime, the consent process shall never delay the response. While we are talking about the consent, the patient might die. But the issue, this legal framework is very challenging. We also encounter previously in our clinical setup. So the all hospitals are recommended to have protocol, and the clinician shall also communicate the hospital management when it comes to the consent issue. Thank you very much.
Thank you, Maria, for that contribution.
Thank you. Thank you, Almariam. The next question is from Richard. He is trying to ask, in a situation where there is a fetal demise, he's asking, is this procedure is ethically accepted or mentally beneficial to the patient to carry on?
Oh, yeah. No, I got it. So, of course, you have said if there is a fetal demise, in this situation, like from experience, what we have done so far, we try to save the mother. If you have seen that there is fetal demise, and then no matter what we do, we know survive that fetus, or maybe resuscitation time have exceeded the golden time, which says that in 4 minutes of resuscitation, you have to start your perimortem cesarean section. At 5 minutes, you deliver the baby, and then you have exceeded that time. Or maybe you have considered that the age of viability is not even up to 28 weeks of gestation according to our own setting, because the gold standard is saying 20 weeks of gestation. So what I have seen we have done here, we have resuscitated. When we had some one of these cases, we resuscitated, and the mother did not survive. And because the age of viability was less than 28 weeks of gestation for our setting, so we did not proceed of doing perimortem cesarean section. So if you have seen a fetal demise, so definitely, what is the essence of doing a perimortem cesarean section?
Thank you very much, Foday.
Yes.
Almari, okay. Any question from the general members?
I've lost my slides. Okay.
Okay.
Any questions, please?
Yes. So, of course, if there is no question for now, if there is no question for now, I would like to at least I'm sorry, I'm still looking on the comment section for questions. At least to say a very big thanks to every one of you. Of course, it's very difficult leaving your busy schedules, work, meetings, etc. HMCS, Cesarean section of CS remains a critical life saving as earlier stated by our presenter. A critical life saving interventions in obstetrics emergency performed during this maternal cardiac arrest.
Unisa, your connection is not good. We can't hear you, Unisa.
Primary aim is to enhance maternal resuscitation by elevating ito caval compressions, thereby improving venous return and cardiac output. Offers to the uterus a chance for a baby, for the mother and the baby to survive. But the primary aim is for the mother to survive. Of course, the timeliness is paramount. Initiating this procedure within 4 minutes, as earlier said by the presenter of maternal cola. Perimortem CS is a shift coordinated actions and I would like to say a very big thanks to each and every one of you, especially to our presenter, Mr. Foday, Daddy Mansaray, for this wonderful and detailed presentation. I would also like to say a very big thanks to you, to Almaria, and to our CEO, Madam Adebosalan. Once again, thanks to everyone that joined us today for this presentation. I'm Unisa, the chairperson for the Operating Room Global Sierra Leone. Thank you very much. Thanks to everyone.
Thank you very much, Unisa, chairperson, Operating Room Global Sierra Leone chapter, for giving me this privilege to speak into this forum. I appreciate every members, and especially the executive members of Operating Room Global Sierra Leone chapter for giving me this platform. I want to thank everybody globally that has listened, has been following this particular presentation. Thanks to whoever has contributed in asking questions and discussions, and which is very key. And this is an educative and learning platform wherein we share our ideas, our experiences in different settings. What might work for me in my settings might not work for you in the settings because of various factors. But which is good that we are here and that we are all together to share our knowledge. Thank you so much, and thank you, everybody.
Thank you very much, Mr. Foday. We would like to invite our CEO to say a word.
Good evening, everyone. I would like to say thank you to Mr. Foday. Thank you for the insightful presentation. You are brilliant at what you do. I really personally gained a lot and learned a lot from you. So thank you so much for doing justice to the topic. And I would like to say thank you to the executives of the TORG Sierra Leone chapter. Thank you for organizing, for facilitating the session. Thank you so much for your commitment and for everything you do. And I would like to say thank you to everyone that joined us, that connected from all over the world. I know everyone is busy, but you still gave it, you still tried, you connected, you gave it all you've got. Thank you. We are so excited and honored to have you join us.
All right.
Thank you to everyone that connected, even on YouTube. Some are watching this live. They couldn't join the Zoom due to internet issues. But we want to say thank you for connecting. Thank you for contributing actively. And we will be glad to have you back. The next webinar will be around 2 weeks' time. It's going to be organized by another chapter in TORG, and we look forward to your contribution. So thank you, everyone. After the session, the evaluation link is going to be on your internet browser, either it's Chrome. One of the links is also shared in the chat box. You could scroll up and see, and the presentation from today's webinar as well. The documentation is in the chat box. So thank you everyone for joining us. We are happy and we look forward to seeing you next time. So thank you everyone. Have a nice day. Bye.
Thank you. Thank you. Thank you.